is Rocky. I'm your student nurse practitioner. For today, I'll be doing your assessment. This video will be uploaded onto YouTube for the course. Is that okay?
Yes.
Okay. So the patient presents at the clinic for lower back pain times 3 days. So we're going to go ahead and start our musculoskeletal assessment. First, starting off with the hands, I'm going to be inspecting the hands. Inspecting for symmetry, any swelling, redness, atrophy, deformities, any nodules as well, and then making sure that I inspect both hands, and I'm going to also be palpating at the distal and proximal interphalangeal as well as the metacarpal phalangeal to both hands. Any pain or tenderness?
No.
Okay, I'm going to also go ahead and do a range of motion test. Go ahead and make a fist for me. Okay, close tight. Okay, and open. Okay, and then so we're doing a flexion and extension of the hand, both active and passive range of motion. We're going to go ahead and do abduction and adduction. So abduction is having the fingers spread out and put your fingers together, okay, and do it by yourself, abduction and adduction, okay. Okay, after that, after range of motions to the hands, we'll go ahead and do inspection of the wrist. Same thing, inspecting for any swelling, any deformities, atrophy, nodules, checking for symmetry of the wrist. I'm also going to be palpating at the metacarpal and the carpals of the wrists. Any pain or tenderness?
No.
Okay. I'm going to go have you face towards me a little bit. Okay. Okay, after inspection and palpation of the wrist, we'll go ahead and do range of motion. We'll go ahead and flex the wrist 90 degrees down. So I'll have you flex 90 degrees, keep your hand straight and flex 90 degrees down, as well as extend and hyperextend 90 degrees upwards. So go ahead and do that by yourself, flex and straight and upwards, okay? Okay, and then we'll go ahead and do the same thing, passive and active range of motion, flexion and extension, go ahead, okay? And we'll also do ulnar and radial deviation of the wrist, which is also known as abduction and adduction. So adduction is basically adding to your towards your body, and then abduction is moving away from your body as abducts. Okay, so we'll do adduction and abduction, abduction and abduction and adduction, and go ahead and do that by yourself. Okay, good. Okay, good. Okay, so after range of motions of the wrist, we're gonna go ahead and do 2 tests for it. The first one is the Tinel sign. So the Tinel sign, I'm gonna go ahead and do flexion of the wrist. Yes, and then I'm gonna be tapping with my middle finger the median nerve. Is there any pain?
No.
Okay, which is a normal finding. A positive finding would be pain that radiates from the palm to the index, middle, and the lateral half of the ring finger. And then same thing, making sure that we hyperextend the wrist and tapping onto that median nerve. Okay, and after that, the second one is gonna be the Phelan sign. So I'm gonna go have you copy me. So you're gonna touch your wrists together. Okay, making sure that we keep that about 40 to 60 seconds. And after 40 to 60 seconds, is there any pain?
No.
Good. That is a normal finding. A positive finding would be there's pain in the median nerve. Okay? So after the wrist, we're going to go ahead and inspect the elbow. Same thing with swelling, any deformities, redness, abnormalities. I'm inspecting for symmetry of the elbows. I'm going to go ahead and palpate as well. So I'm going to be palpating the olecranon process, the medial and lateral epicondyls, as well as the extensor surface of the ulna, making sure that I palpate all 3 of those spots, or 4 of those spots, and making sure that I do it to both sides bilaterally to the both elbows. And basically for the epicondyles, if there's the difference between the golfers and the tennis elbow is that the tennis elbow is at the lateral aspect of the epicondyle, and then the golfer's elbow would be at the medial or the inner part of the elbow, medial epicondyle. But was there any pain or discomfort, any tenderness? Okay, after that we're going to go ahead and also do a range of motion to the elbows, making sure that we flex and extend, and doing passive range of motion as well as active range of motion by himself. And same thing, passive range of motion and active range of motion by himself. And we'll also do supination and pronation. Okay, and same thing, supination and pronation, and go ahead and do it both times. Okay, and after range of motion, we'll go ahead and test for the shoulders, making sure that I inspect both bilateral, anteriorly and posteriorly, checking for any swelling, any deformities, abnormalities, redness, any nodules or lesions, as well as for any signs and symptoms of inflammation or tenderness. So I'm going to go ahead and do a palpation, making sure that I note for tenderness or any fluids. So I'll go ahead and stand behind you. Okay, so I'm going to be palpating his acromioclavicular joint, which is on top of the shoulders. I'm also going to be palpating the cricoid process, as well as his biceps groove and subdeltoid, his subdeltoid bursa and tubercle of the humerus, making sure that I palpate to both sides, the cricoid process, acromio, tubercle of the humerus, as well as the subdeltoid bursa and the biceps groove. After palpating the shoulders, making sure there's no tenderness or any fluid present. Was there any pain or discomfort?
No.
Okay, and so after palpating those areas, the shoulders, a little bit in front and on the sides, we'll do a range of motion. So we're going to go ahead and do flexion of the shoulder. So we're going to go ahead and flex forward, up, and then back down, and then backwards for extension. Okay, good. Okay, and then after flexion and extension, we'll go ahead and do abduction and adduction. So abduction is away from the body, and adduction is back to the body. And then I'll have you do internal and external rotation. Go ahead and place your arm to the back of your hand to the back. Okay, and then place your hand to the back of your neck. Okay, good. Okay, so making sure we do both passive and active range of motion, and doing it on the same other side. So we'll do flexion, we go straight forward, and then extension straight back out. Okay, and then we're gonna do abduction and adduction, and go ahead and place your hand to the back, okay, and to the back of your neck. Okay, you can go ahead and relax. So making sure you do range of motions to all those areas. After that, we're gonna go ahead and do a special test for the shoulders. There's numerous tests, but this test is called the SPEEDS test. It's basically testing for bicipital tenderness. So what I'm gonna have you do is put out your hands in a supine, and we're gonna go ahead and go against resistance. I'm gonna go push down. Okay, good. Okay, you can go ahead and relax. Is there any pain or discomfort?
No.
Okay, so with that, that's a normal finding. A positive finding for the speed test would be there's complaints of pain as you do apply resistance or pressure to the hands. That's because it's putting stress onto the biceps, which would be indicative of bicipital tendinitis. So after doing a speed test for the shoulders, we'll go ahead and move on to the head and neck. So same thing, I'm going to be inspecting for symmetry. I'm inspecting for swelling, any redness, nodules, none noted. I'm also inspecting for any abnormalities or deformities noted where everything is midline and symmetrical. And then after that, we're going to go ahead and go towards the back, checking his posture, and we're going to go ahead and palpate with his, we're going to go ahead and palpate his temporomandibular joint, which is located right here. So I'm going to go place 2 of my fingers by the temporomandibular joint and open and close it for me. Okay, good. One more time. Okay, close. No popping or clicking, but was there any pain or tenderness for you? No. Okay, good. So that's the assessment for TMJ. And after that, we're going to go ahead and palpate his cervical spine, his neck area, so you can, and a lower neck as well. So you can go ahead and turn that way the camera can see a little bit. Okay, so we're gonna go ahead and let me know if there's any pain or tenderness, palpating the cervical spine, paracervical muscles, down to the rhomboids as well as the trapezius and the sternoclavicular as well. Okay, checking for any pain or tenderness. Any pain or tenderness?
No.
No. Any discomfort?
No.
Okay. 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 After that, we'll go ahead and do range of motion to the head and the neck. So we'll go ahead and do flexion. So go ahead and touch your chin down to your chest, okay, and then put it back up, okay. So okay, and you can relax, testing for flexion and extension. After that, we'll do rotation. So you're gonna go ahead and rotate from side to side, okay, good, okay, and then we'll do lateral movements to have your ear touch to the side of your shoulders and the other side. Any pain or discomfort?
No.
Okay. Now I'm going to be testing the patient, his jaw. So go ahead and open and close your mouth. Okay, good. And one more time. Okay, good. And then open and move side to side your jaw. Good. Okay, good. So making sure that as I do that assessment, the 3 widths of the finger vertically can also fit into his mouth. After that range of motion to the head and neck, we'll go ahead and do a special test for the head and neck. It's called the Sperling's test. It's also known as the cervical compression test. So I'm going to have you put your ear to the side of your shoulder, and then I'm going to be applying downward pressure to it. Any pain or discomfort?
No.
Okay, and then the other side, and same thing, applying gently downward pressure. Okay, go ahead and relax. So no pain is a normal finding. Complaints of pain or discomfort to the neck would be a positive Sperling's test or positive for cervical compression test. And this test for cervical radicular pain or paresthesia. So you have to be very careful with using this in elderly or frail patients, especially with serious or traumatic injuries as well. Okay, so after testing for the head and neck and for the upper extremities, we'll go ahead and move over to the lower extremities. So first off, we'll go ahead and inspect the feet and the toes. So for that, we're going to be inspecting for any swelling, any calluses, corns, any bunions, any plantar warts. We'll go ahead and assess for flat feet as well. So I'm going to go ahead and have the patient stand up so that we could observe flat feet, and then we'll go ahead and lie down. So no flat feet, noting arc as well. Okay. And then after that, we'll also go ahead and start palpation of the interdigital neuroma, plantar fasciitis, as well as palpating the distal and proximal interphalangeal and metatarsals. So you can go ahead and lie down for me. That way the camera can see. Okay, good. So making sure that inspecting symmetry and palpating both the interphalangeals and metatarsals. After that, and interdigital neuroma and plantar fasciitis. We'll go ahead and do range of motion. Go ahead and flex your toes for me. Curl up your toes and open up your toes. Good. Okay, one more time. Curl up and open. Good. Okay, and then we'll also do range of motion where we invert the foot and evert the foot, which is internal rotation. Okay, and outwards. Good. Okay, and we'll do the other side. Invert and outwards. Okay. After the inversion and eversion of the foot, we'll go ahead and assess the ankles. So for the ankles, we're inspecting for any swelling, symmetry, deformities, atrophy, any abnormalities, redness, nodules, any pain and tenderness as well. Checking for any discoloration of the ankles. We'll also go ahead and palpate for any nodules or tenderness to the ankles. Checking for the malleus as well as the Achilles, both medial and lateral aspect of the malleus. Any pain or tenderness?
No.
No. Okay, good. Okay, and then we'll do the other side, making sure you assess both sides and the lateral and the medial as well as the Achilles. Any pain or tenderness?
No.
No. Good. Okay. After palpation of the ankles, we'll go ahead and move over to range of motion. So we're going to go ahead and do both active and passive range of motion. So I'll go ahead and do it for you first. Supporting the ankle, doing dorsiflexion, plantar flexion, as well as rotation. So we'll go ahead and dorsiflex towards pushing the foot towards you, and then pushing the foot away from you, and then rotation of the ankle, and then back, and then the other way. Okay, doing it at the other ankle as well. Dorsiflexion, plantar flexion, rotation, and outward rotation. Okay, so I'll have you go ahead and do the same thing: dorsiflexion, plantar flexion, rotation, and the other way around. Okay, and same thing: dorsi, plantar, rotate, and the other way around. Okay, so after rotation of the ankles, we'll go ahead and move over to the knees. We're gonna same thing. We're inspecting the knees for any swelling, any deformities. We're inspecting the knees for symmetry. For any abnormalities, nodules, visible lesions. After inspection of the knees, we're going to go ahead and do palpation. So we're palpating the suprapatellar pouch, the sides of the patella, as well as the popliteal fossa, which is right behind the knee. So making sure, so for the popliteal fossa, you're checking for any cysts, particularly Baker's cyst, and if it's present, normally patients would have a harder time with flexion of the knee. So making sure you palpate both sides, checking the patella and the popliteal fossa, checking for any cysts or tenderness. After palpation of the knee, we'll go ahead and do 5 different tests, special tests for the knee. So the first test is called the valgus stress test. Basically, I'm going to be This is checking for lateral meniscus injury. If there's any pain present during the test, it is a positive finding or a positive stress test. So I'm basically, for the valgus, I'm going to be placing one hand at the lateral aspect of the knee, and then placing the other hand at the medial aspect by the ankle, and then, or the foot, and then I'm basically going to be abducting. And is there any pain?
No.
No. Okay, and then I'm going to do the same thing, lateral aspect and medial, okay, of the ankle, okay, and abduction. Any pain?
No.
Okay, so negative for the valgus stress test. Now we're going to go ahead and do the varus stress test, which is particularly the same thing, but opposite. So I'm going to take one hand, put it medial aspect of the knee, and then the other hand at the lateral aspect of the ankle, and I'm going to be basically doing an adduction motion of the lower leg. Any pain?
No.
Okay, and same thing, medial, lateral, adduction. Any pain?
No.
Okay, so after, so that's a negative varus stress test. Again, a positive stress test would be complaints of pain during the test. Okay, so the next one is called the Lachman's test. For the Lachman's test, I'm going to have the patient continue lying in supine, and I'm going to have him flex his knee about 20 to 30 degree angle, and I'm going to have my hand basically one hand is going to be right by the lower femur, and then the other hand is going to be at the upper greater tuberosity, and I'm basically pulling and pushing the tibia, assessing for any pain, for any tenderness, assessing for laxity of the anterior and posterior tibial ligaments. So a positive finding for this would be a boggy or soft feeling. There would also feel like some sort of displacement. So we're going to go ahead and do that to both knees. So I'm going to go ahead and lateral pushing and pulling. Any pain or tenderness? Okay, so after that, so it's a negative Lachman's test. After this, we're going to go ahead and do a Drower's test. Basically, I'm going to have the patient stay in a supine position. We're going to go ahead and flex the knee about 90 degrees. We'll start off with this foot. Okay. And basically for this test, for the examiners lightly sits onto the foot to support the patient's leg. So I'm going to be sitting on the patient's foot as the knee is flexed, and I'm basically going to be holding on to his knee, and I'm going to be pulling his knee, pulling and pushing his knee to be able to test Drower's test anteriorly and posteriorly. So I'm pulling his knee more so for the upper extremity as well. Any pain or tenderness?
No.
And no boggy or soft feeling as well. No displacement. So again, you're checking both anteriorly and posteriorly for the Drower's test, assessing for any laxity of the ligaments as well, making sure that you sit on the patient's foot and the knees are flexed and you grab onto the upper leg and pull it both anteriorly and posteriorly to check on both tests. The next one is called a McMurray's test. It's basically, we're going to be medially rotating the tibia. So you're going to go ahead and extend your leg. Okay, so I'm going to have him, I'm going to flex the knee and medially rotate the tibia. Okay, and I'm going to be extending and flexing at the same time his knee. Okay? Okay, and doing it on the other side, making sure that you do all of the special tests to both sides as well. So making sure that I do the valgus, varus, the Lachman's, the drawers, and the McMurray's test on bilateral knees. So I'm going to go ahead and do for the drawers test, it's a little bit more difficult to do, but you'll, again, same thing. I'll have the patient be sitting on the other edge of the bed and pulling anteriorly and posteriorly for the drawers test. And for the McMurray's test, I'm going to go ahead and medially rotate and flex and extend the knee. Okay, and I'm basically checking for any pain, any tenderness, assessing for laxity or crepitus of the knee. Is there any pain, discomfort, any tenderness during the test? Okay, so after the assessment of the knees, we'll move on to the hips. So for the hips, I'm going to be inspecting for same thing, symmetry, swelling, any atrophy, deformities, any redness or nodules as well. Making sure that I practice on one side of the bed and then make my way to the other side. Okay, so I'm going to have the patient start off as in a supine. Maybe we can, I'll move over to the other side. Okay, so after inspection of the hips, I'm going to go ahead as well as palpate the anterior superior iliac crest, the greater trochanter, as well as palpating the posterior superior iliac crest, as well as the sacroiliac joint, which we'll do as he turns backwards. So after the palpation, we'll go ahead and do a range of motion. So we'll go ahead and do internal and external rotation first. So we're going to go ahead and flex the knee and rotating, internally rotating and external rotation of the knee, returning to original position at each time. So both doing it passive and active range of motion. So same thing. We'll go ahead and bend the knee and internal rotation as well as external rotation. Okay, and original position. Okay, after that we're gonna go ahead and do flexion, both active and passive range of motion of hip flexion. So I'm gonna go ahead and just flex at the hip and down. Okay, and go ahead and do it by yourself. Okay, good. So doing it both passive and active range of motion. Okay, and do this one by yourself. Good. Okay, and then after that we'll also do, so go ahead and face this way. Yeah. And we're gonna go ahead and do abduction and adduction. So abduction and adduction. And go ahead and do that by yourself. Okay, abduction and adduction. Okay, and go ahead and lie onto your stomach. Okay, and then we're gonna go ahead and do an extension. So I'm gonna do a passive range of motion for extension, supporting his ankle, his lower extremity, and doing an extension. Okay, and doing passive range of motion to the other side. Good. Okay, and go ahead and do that by yourself. Good. Okay, and other side. Good. Okay, so after that, you can go ahead and lie on your back. Oh, we'll do this side as well, for abduction and adduction. So abduction and adduction. Okay, you'll go ahead and lie on your stomach. On your back. Okay. So after range of motion for the hips, we'll go ahead and do a special test. The first one is called the Thomas test, and we're gonna go. Basically, this test tests for any hip flexion contracture. So I'm gonna go ahead and have you flex your knee and bend your knee, and then pull it towards you and your abdomen. Okay. Any pain or discomfort?
No.
Okay. And we'll go ahead and do that to the other knee. Flex and pull towards the abdomen. And basically, no pain is a normal finding. A positive finding of this would be complaints of pain during the test, or the patient is unable to fully extend back his knee or his lower extremity. After this, we'll also do a Patrick's or Faber test. This test is testing for the flexion, abduction, as well as the external rotation of the hip. So we're gonna go ahead and I'm gonna place his ankle right above his knee, flexing that knee, flexing the right knee, and then right above his patella, as you can see, and I'm going to apply gentle pressure downwards. And is there any pain or discomfort? No. Okay. And then doing the other side as well, making sure that the ankle right above the patella, pushing down. Okay, any pain?
No.
Okay, and that's a normal finding. A positive finding would be there's pain as you perform the test. So after the assessment of the hips, we'll go ahead and move over to the assessment of the spine. So I'll have the patient stand up for me. Okay. Okay, so for the spine, we're doing inspection of the spine. I'm going to be doing an overall inspection of the spine, checking for the symmetry of the shoulder height as well as the iliac crest, checking for and the curvature of the spine, for any lordosis or kyphosis. I'm also going to be inspecting the skin creases of bilateral buttocks, making sure that that's even as well. After inspecting the overall spine, we're going to be inspecting the dorsolateral spine. I'm going to go ahead and ask the patient to bend forward. Go ahead and bend forward for me, trying to touch your toes. So at this time, I'm going to be inspecting the curvature of his spine, checking for scoliosis. And then as he bended forward, I inspected, you can go ahead and stand up. I inspected the movement and symmetry of his shoulders as well as his iliac crest. After that, I'm going to palpate the spinous process as well as his intervertebral spaces. So making sure you palpate down. Any pain or tenderness?
No.
No. Okay. Palpating down the spine. After that, I'm also going to be percussing the spine using the ulnar aspect of the fist. Okay, and palpating the spine. Going down the spine. Okay, after the percussion of the spine, we're going to go ahead and do range of motion. I'm going to have the patient bend, do lateral movement, which is bending from left and right. So go ahead and bend left and right, and good. Go straight ahead. And then I'm also going to have the patient bend backwards a little bit. I'm making sure I stand back. Okay, go ahead and bend backwards. Okay, good. and just go ahead and straight. And then earlier he was able to bend forward. And then now we're going to do a twisting motion or rotation of the spine. So go ahead and rotate left and right for me. Good. Okay. Okay. After rotation, range of motion of the spine, we're going to go ahead and do a special test of the spine. So this involves the patient lying back down. Okay, go ahead and lie down. Okay. I'm going to go ahead and move the camera that way again. Okay. So as the patient is lying down, go ahead and raise your leg as high as you can. Okay. And then at this time, I'm also going to be supporting the patient's leg, raising it as high as I can. So, and then we'll check the other leg as well. Is there any pain or discomfort? No. Okay. Which is a normal finding. A positive finding for the straight leg exercise or test would be if they are complaining of pain as you lift up their leg, and it's only below 45 degrees. So that would be a positive finding for the straight leg raise test. Again, if they complain of pain below 45-degree angle, at this case he is not complaining of pain, which is a normal or negative finding. But otherwise, this concludes my musculoskeletal assessment. Do you have any questions or
No,
concern?
no, thank you.
Okay, and thank you. Have a good night.